Welcome everyone to the April 14th edition of CAEP National Grand Rounds. Before we get started today, we have a video update from Dr. Rob Woods at CGEM. Over to you, Rob.
Hi, I'm Rob Woods, the chair of the Education Scholarship Committee and one of the decision editors for the Canadian Journal of Emergency Medicine for Education Research. I'm reaching out to you today to let you know about some of the amazing education research you're going to see at this year's CAEP conference. On the afternoon of Wednesday, June 17th, we have our Education Innovations competition where you get to vote for the winner. In that evening, we have our moderated education posters, and the following afternoon, we have our education research lightning orals. As a decision editor for education research, the main message I'd like to get out to people is that education research is a lot different than clinical research, and it needs to be approached in a different way. We often think of a novel way to teach something or a new curriculum, and we want to measure it like we would a randomized controlled trial. Did people learn more? Did people like it? The challenge with this is that anytime something's new or novel in education, people are going to like it, and probably in the context in which it was developed, it's going to work well. But a better question to ask is, why did it work? So that others who want to do it in the future can understand why it worked and they can adapt it to their local context. One way to try and understand why an education intervention works or does not work is to view it through the lens of an education theory or framework. If you haven't done this type of work before, I'd suggest reaching out to a mentor to help you guide you through this process. We also run a workshop each year through our Education Scholarship Committee to help to guide you through this process of your education scholarship journey. We're also looking for new members in our committee who are up-and-coming clinician educators to join our community of practice. We have an open meeting at CAEP. We hopefully get to see some of you there.
Thanks, Rob. My name is Amy Kernick, and I'm honored to be the moderator for tonight's presentation. I'm an emergency physician practicing on the Saanich Peninsula, and I'm the chair of the CAEP Rural, Remote, and Small Urban section. While this is a virtual event, I'm presenting today from the traditional territory of the Wasanich peoples of the Coast Salish Nation. I would like to acknowledge with gratitude the traditional owners and caretakers of these lands, and the lands where other presenters and viewers are joining from. Today we are discussing healthcare challenges in rural and remote Canada, which often includes Indigenous communities. Acknowledging the traditional territories on which we reside is one small step in recognizing our colonial history and the disparities that have happened as a result. I also want to acknowledge the challenging times that we are in, and to thank all of the viewers, support staff, and presenters for joining today, despite the stresses of the third wave. For some housekeeping, CAEP's Scientific Planning Committee has reviewed all of our participants' declarations of conflicts of interest, and no conflicts, perceived or real, have been identified. There have been no external support received for this webinar. Tonight's talk is titled Rural and Remote Healthcare Transformation, Exploring the Potential for Telemedicine. We have an exciting lineup of speakers and panelists from both Ontario and BC. This is including physicians, researchers, technical consultants, rural emergency nurses, and critical care transfer paramedic. We will begin with two 20-minute presentations and end with 20 minutes of a panel discussion and question and answer period. Please send in your questions in the chat box or by text to the number on the slide. Thank you to those of you who have sent in questions in advance. These are the objectives for tonight's presentation. At the end of this activity, participants will be able to 1. Recognize the expertise and unique experiences of rural practitioners. 2. Discuss challenges with working in rural and remote environments, including Indigenous communities. 3. Work towards better system integration and strengthening care in situ. 4. Learn about the concepts of virtual hospitals and Locum Plus. 5. Explore ways to support rural practitioners at critical skill acquisition and maintenance. I have the pleasure of welcoming our first speaker, Dr. Lori Mazurek. Lori has over 25 years of experience working as a critical care transport and emergency physician in Toronto. She took a leave of absence for the past year to do locums in rural and remote Canada and to listen to and learn from local experiences. She will be sharing with us her learnings and her project titled Stronger. Thank you, Lori, for joining us today.
And thank you so much, Amy, for having me. I'll tell you that it's been an incredible year, and I've learned a ton, and still there's so much more to learn about rural and remote clinicians, including the nurses that do an incredible job, often on their own or just supported with telemedicine. So I had no idea of the expertise out there, and I'm glad to have my ignorance erased. And so I'll share what I have learned. As Amy said, that I have taken a year off from a large trauma center, Sunnybrook in Toronto, mainly because as an Orange physician, which I do Ontario, basically air ambulance medical transfers, I've been talking to remote and rural communities for years, helping them to move patients to higher levels of care, seeing firsthand the obstacles to do that, and in many respects, a lack of support. And but in this year, taking the time to actually do locums in all these communities, not all, in some of these communities, to actually have a better understanding. So Orange, which is our air ambulance, is a supporter. Health Force Ontario, which is a government agency, Ontario Health North, also government, and Northern School of Medicine have all taken an interest and have been with me along the way in trying to find ideas about how telemedicine, shared education, and collaboration could strengthen care in situ. So I'll tell you straight up, what I have learned is actually so much more from you guys that the South needs to know. So I do thank you for that. So the visits today, COVID altered where I was going. Interestingly enough, I have ended up predominantly in First Nations communities. The ones that are highlighted in yellow are small communities that have hospitals, but they are run by hospitalists and family doctors. All of those three, with the exception of Red Lake, have a CT scan. All the others are actually nursing stations where family doctors may fly for a week to 2 or possibly 3 weeks out of a month. And some of these communities are up to 4,000. So if you can imagine, these really are outpost types of communities, and nurses dominate the care there. And so that's why we have nurses, or one of our nurses, on the line. First impressions, honestly, it felt like going back in time. So I'm using older pictures, but I think they reflect an incredible pioneer type of sort of resilience. These are communities that in many instances don't have running water, and certainly many don't have potable water, and there may be quite a few people that are heating their houses with wood, as opposed to the traditional types of things that we think of in urban or rural settings, where you really have everything that you need. You don't have it there. There may be fly-in or ice road sort of access to some of these things. And then when you move further south, there's access, but there is still very limited resources and larger communities. The First Nations communities, again, just an incredible eye-opener, is the dominant theme of spiritualism. And it struck me in many of our meetings that I have gone to, everything being virtually now, it's like, let's just get to business. And all of these meetings that I have, and it was incredible, sort of like moving type of thing, started with a prayer and ended with a prayer. And it kind of just sets the tone as to why are we here. We're here because we have families, because we have people that we love, and we have a community that we care about. And there may be people with diverse opinions trying to do things together, but we need to first and foremost remember it is our goal to serve and support these people and ourselves that really joins us and unifies us in a common goal. And I found that doing this really set the tone, and I almost suggest that it should be done really for almost every meeting, because I think it does make a big difference on how people then subsequently collaborate. The respect is incredible. There is, again, this is First Nations. This is certainly nothing that I've experienced in the usual meetings that I've been to, but I do find that this setting of the tone, the respect, they have something called Pass the Feather, and Howie's online. There are other versions of this, but essentially everybody is given a chance to speak who wants to speak. And even if you take this feather or this opportunity and you have nothing to say, silence itself is considered something respectful, and that people like say that you hold it and you just really pause, that it again sets the tone of the conversation and how we move forward on trying to solve some difficult challenges. Clinicians, I cannot get over the commitment of people, their efforts to try to do anything and everything within their means to be innovative and intuitive and not see everything as an obstacle, but in fact just see it as a challenge that's going to make them stronger, and that they will, through their dedication, find a way to solve or to just adapt to the situation without being overwhelmed by many times very difficult sort of challenges. And I have to say, this is in most hospitals that I was at, I don't think there's anybody from the territories here, but I'll just use Yellowknife working in their emergency as an example. Holy CRAP. You are working as a consultant, you're talking to the nurses in the remote nursing stations, you're talking to consultants in Edmonton, you're trying to arrange transports, you're trying to run an emerge, which is almost impossible. You admit patients, which takes forever. And if there's a code or a delivery, you have to run there. And so I almost had a heart attack running up flights of stairs, which I haven't done in many years. And it's just like, it's not, this is one thing I don't think I would accept, is this traditional incredible burden of work. We often think in the South, because we have wait times of, 12 hours can, in my institute, not common, but certainly occurs, thinking that's unsafe. I got to tell you, having one doc try to do everything's not safe either, but that's another day, another story. The nurses are incredible. This is Florence Nightingale. They definitely, if there was not the nursing outposts, at least in Ontario and certainly in remote places elsewhere, and maybe in rural, it's not quite the same, but the amount of work and clinical care they contribute is just astounding. And they often work well beyond their scope, doing IOs and resuscitations without a physician there. There's a lot of things I didn't expect. And I'm probably reflecting Ontario, but Ontario may reflect elsewhere, that in some communities, a SAV is the ambulance, a nurse and a driver, again, going back like, 60 years in other places. And in the same province, similar communities having full EMS. So there was also paper, a lot of nursing, and this is a problem everywhere, that we still don't have the single EMR. It fractures the patient record, making it extremely difficult. And I was incredibly surprised by the lack of communication between health units and health agencies, and something that I call pocket funding. It's happening here. I'm guessing that it's happening elsewhere, where one community will get money to do their own EMR, and another community will get money to get an EMR, but it's not the same EMR. And in this day and age, people move around, and the fact that the government is still doing this one-off kind of funding, and it's happening now as a result of COVID, pop-up kind of telemedicine is flourishing all over the place, but it's fragmented. And unfortunately, I think it's actually making it worse for clinicians and the patients themselves, because it's not coordinated. So what are the ideas I found? Well, I have to say that the First Nations communities, who I think are in the most difficult situations by far of any kind of communities in Canada, have it right. And they talk about healthcare transformation, starting with a form of spiritualism. And I did not know this. I thought traditional medicine would be the same, but it's no different than anything else. When you have different communities, you have different types of traditional medicine, but the bottom line, it's a form of spiritualism and respect. And I think without that trying to transform healthcare is really impossible. So having that as the first and primary goal, I think is huge. They often start, as I said, with a prayer and end with a prayer. It's all about supporting themselves as individuals, but more so their community, their family. And they support and pray for all races. There's none of this sort of one over the other. It's all about working together and unified. And Howie's probably going to correct me on everything that I'm saying, but Howie, this is just my observation. But working as one with as sort of almost a global community, but also with nature itself. So they have a vision, and we're working very hard on something they would say healthcare, hospitals without borders, but it is transitioning to healthcare without borders, hospitals looking after the most acutely injured or and probably the most urgent things, but there's so much more like preventative medicine and sort of chronic care, et cetera, so it really should be healthcare or will be healthcare without borders. So the ideas I'm going to present, some are from First Nations, but and other clinicians. Without a doubt, the clinicians that I've met who are like me, sort of moving around the concept of a single federal, sort of a provincial territorial license for all of us would help a lot. I think I had to apply, honestly, I think at least 20 times. Every hospital you applied to, you had to do the same application process. It was so ridiculous, and took me months to finally get privileges in certain locations, which should never happen. If you're qualified in one part of the country, you should be qualified in another. They can always have their pound of flesh and take whatever money they need to to maintain the registry. But this is even more important than ever, because as you know, I'm actually sitting in Toronto, where we're being crushed by COVID, and we are so running out of resources, and we want to bring people in. And after 30 years of talking about this and possibly more, we still are no closer to doing this, but maybe COVID can accelerate it. A single EMR, the fracturing of patient information is probably one of the biggest challenges. When I was in Yellowknife, I had a guy with a subdural, and I'm trying to talk to somebody in Edmonton, and of course PHIPA doesn't allow this or that, so I'm violating everything that has PHIPA with taking my WhatsApp and scrolling and filming the epidural, or sorry, the subdural, etc. This shouldn't have to be like this. It should be one chart, the patient, and it exists, the whole concept of my chart, one chart, and it should be uniform, and the person who owns it is the patient, and they give us permission, not PHIPA, but the patient gives us permission, and it should be a nationwide sort of access. Virtual hospitals, one of the concepts that came up in many of the smaller hospitals, that if they can consult clinicians, they often have a hospital that they're attached to. So I'll use Moose Factory, which is a small community on James Bay Coast, works with Kingston. But when you consult their clinicians, whoever they are, they're great, don't get me wrong, but they're also working. So they really don't have the kind of time that you might need to spend with them to sort things out. So this virtual hospital, it consists of clinicians who are just on call, who maybe have a wider territory, let's say, in order to generate the patient volumes that they need. And they spend time with you, and they may spend up to an hour with you to go through patients and things like that. And this is, it's just like working in a hopefully not too busy physical hospital, and allows you to form a relationship with a consultant that continues beyond just, yeah, can I send them to you? Yes, you can, bye, which is a bit, unfortunately, what happens now. So the other idea is, especially in the nursing stations, but I certainly have heard it from clinicians, one of the highest stress situations is they're in a resuscitation and they want some help. And, it's like call the trauma, go through one service to get to a clinician who's working and is busy. And so this would be dedicated virtual care. If you need a cardiologist, let's say, if you need another set of eyes, like so you get a second emergency physician to assist you in trying to sort out how to resuscitate. Or if you're a nurse in that situation or a medic in this situation, you get immediate virtual support, and then layering it down from there. So you might have somebody who's 911, then you have another team that's dedicated for longer periods of time. The other thing, actually, the bottom of this is the virtual rounds. One of the things that came up to the hospitals, they would love to say, because they're, as a hospitalist, many of their patients have medical problems. They would love to do rounds with the internist. And there are very inexpensive walk-around robots now that you can do these types of rounds. And it certainly would be inexpensive to do. The trickier part is funding the consultations. But as somebody who does transports, I would much rather see this funded than the incredibly expensive transfers to physically have these patients flown out to see these people, when many times you're able to manage them in situ. In this situation too, as well, the teleconsultant has the authority to authorize the transfer. So there's none of this arguing. And trust me, as a as a transport doc, the amount of arguing, and then now that I've been in the boots of people trying to arrange some of these transfers, the arguing is just sometimes incredible. In this situation, the teleconsultant feels that it is appropriate to transfer, the receiving must accept. And then it's up to another sort of, in Ontario, they call critical, would find you the bed. The consultant also then stays with you, talks to you about management, because it does take time for the transport teams to get in there. And although sometimes I, as a transport physician, will also perform that role of supporting care in situ until we arrive, I think it's best handled by, like if it's a neurosurgical problem, work with them. And they stay with you because they're not on shift and they're not also busy, and they can have time for more than just send them as the words that come out of their mouth. I think a lot of this is already happening, book virtual appointments. Certainly COVID has pushed this, and I hope that it's maintained afterwards. Doing all follow-up. We were still transferring people just to go see fracture clinics, just to say, hey, your ankle's doing great. Well, you don't need to do that. There's a lot more effective ways to use money. And we're in Toronto, and I'm sure elsewhere, doing virtual and non-emergent consults for our actual emergencies now, so people can call in. Virtual primary care practices came up, especially for clinicians who are flying out remotely, who aren't in community at all times. And in between, how can they maintain contact and sort of care? So it's the idea that you have a family practice team, but it's now virtual. And you guys probably know far more about this than I, but the beauty of it was that if you, regardless of who you are, where you are, if you're not always in community, you can be part of that community afterwards, just through continuing to follow up and inform, follow up with patients and results afterwards because of the virtual technology. How do you solve staffing in remote areas? I'm not sure you can always not have locums come in. I think it's inevitable. There's pros and cons. One, by them working in busier centers, they do maintain their skills. In some of the patients areas that I worked, I don't know that I could have maintained my skills, that I really needed to be exposed to the higher acuity in a busier center. So I think there's value to continuing to have locums. But the one thing is, and I do think being able to do telemedicine is a career lengthening option. And I have done this for critical care for about 25 years, and I can guarantee that. And it maintains your skills, at least intellectually. But the deal would be, if you want to do telemedicine, that you actually work in these communities. So if you formed your virtual hospital and you had the teleconsultants, they would actually have to work some part of their time in the communities that they serve, or at least a similar community, so they actually understand what it is. When you make a recommendation, say to a nursing station, yeah, go ahead and intubate them and put them on pressors. Sorry, do you even know what you're talking about? So it's surprising and unfortunate how many times consultants really have no idea of the conditions under which you work. And they have set expectations of what you should be able to do when there's no possible way. But this would ensure that by working there, they would have an understanding. And by forming these relationships, I think it would make them smoother, that you would be trusting of them. They would work with you. And when transfers came, it would be easier. Bed shortages aside, but it certainly would be easier, I think, to make happen, because they know what you're under. They know you. And I think, when you have these relationships, they're more likely to support you. Something else is the clinical expertise that's in the North is incredible. It's housed in many of the Northern nurses, medics, and although neither seems to involve PAs, having worked with PAs, I think they have a phenomenal asset. And just even having these types of clinicians in your own sort of rural emergencies that deal with high acuity events on a relatively regular basis would actually put you at ease. But the option too, as well, and I did talk with Nazem about this in Orange briefly, why not offer them a shortened MD program, and rather than force them to go back and get, especially medics, to go back and get some sort of bachelor's of biology, which would probably degrade their skills, provide no real value to their skills that they have already, and offer them shortened MD programs, something like do a competency assessment and offer like 12 to 18 months, really a clinical clerkship, and then put them into a rural generalist stream in return for a return of service, because they are not going through the traditional sort of, bachelor's, master's, whatever type of thing, but they're proven clinicians who have already dedicated themselves to the North. They know the North. Their placements could be in the North, but it doesn't have to be just North. It just happens to be where I've had that experience. Because of their, I know, having seen what they do now, they would be incredibly, incredible assets to rural settings too, as well, because of their ability to deal with emergency and crisis types of situations. So is this feasible? Without a doubt, and essential. The top 4 things I would say to pursue is the single FTP license, the single EMR chart, virtual hospital and consults with a locum plus who in exchange for doing virtual care actually works a certain percent of their time in the abbreviated MD program. I put the COVID virus there because I think COVID is putting the pressures on and has the potential for us to leverage it and accelerate this. So hopefully I didn't run too far over my time, and I'll stop there.
Great. Well, thank you, Lori, for your presentation and also for your effort in trying to understand the rural perspective. So really appreciate that you're doing that to help bridge the gap. Next up, we have a team based in BC that will actually discuss some of these solutions to Lori's questions. Their tool is called Real-Time Virtual Support, and we'll be hearing from a group of 5 experts. First is John Polovich, the director of the Rural Education Action Plan and the Virtual Health Lead for Rural Coordination Center of BC. He's also the co-founder of BC Virtual Health Grand Rounds, and that's been ongoing since 2016. We also have Dr. Kendall Ho, an emergency physician, lead of the Digital Emergency Medicine Unit, and the medical director of HealthLink BC Emergency Eye Doctors in Assistance, or HIDE. He's also the lead of the Real-Time Virtual Assistance Pillar for the BC Emergency Medicine Network. And we've got Dave Harris, the technical lead for the Rural Coordination Center of BC and the lead for the RTVS project. He specializes in designing virtual care solutions to projects that are deemed not possible. We've got Dr. Bryden Backlaws, an emergency physician in Powell River and the co-lead for the RTVS program in its emergency arm, Rudy. He's also the lead for the virtual SIM program and the BC Rural Resident Rounds. And finally, I'd like to welcome Dr. Helen Novak-Lauser, an associate lead of digital emergency medicine at UBC, where she leads a team working on research and evaluation in digital and virtual health. Welcome to all of you. Over to you, John.
Thanks so much, Amy. And just want to say thanks to hosting our Team BC to these rounds. Real honored to be here today. And I'm calling in today from the traditional territory of the Stolo Nation here in the Central Fraser Valley, about an hour east of Vancouver. This is our team that will be talking. We'll kind of chunk it up into quick 4-minute segments, if that's okay. This talk from BC is really predicated on a lot of partnerships and really a lot of trust and relationships between many of the stakeholders in BC to bring what we're going to share with you today together in the last year. The objectives, really, we're just going to review what the real-time virtual supports are in BC, why they were created, and we'll kind of discuss quickly which pathways support patients and which pathways support healthcare providers. And this is our agenda. And I'm going to start with this picture. This is the community of Takla Landing in north central BC. I took this last month when I went up with the Moderna vaccine, and I go to Takla every month as part of my regular visitations to 5 other remote Indigenous communities in north central BC. And I think Takla epitomizes well the reason we need virtual care to support not only emergency medicine care, but longitudinal relationship-based family medicine care, rural generalist care, as Dr. Mazur alluded to earlier. And really in the last decade, we've spent a lot of time cutting our teeth in BC in Takla Landing as it pertains to virtual health support. So RTVS, what is it in a nutshell? Really, I want to just tease this out very quickly for everyone. This is RTVS is really about calling a friend. It's about if the same critically ill patient showed up in the center on the left, which is shows the doors of Vancouver General Hospital, or the facility on the right, which is the Stewart Health Center, that same patient would be met very differently. And on the left, there'd be a squadron of healthcare providers with a sub squadron and the floors above the emergency room. In the Stewart Lake Health Center, there'd be a single doctor and a single nurse. And so in the spirit of equity and access to clinical support, but also professional support, we created the Real-Time Virtual Support Network, which is really Call a Friend. And as I alluded to earlier, really, you can think of RTVS in a dyad in terms of the pathways that support patients and the pathways that support providers. I'm just going to touch on the patient-facing pathways for a moment. These were all created last March as kind of a response to COVID. With the First Nations Health Authority, we created the First Nations Virtual Doctor of the Day program, which reaches out to all Indigenous patients, urban and rural, and they can access this program. These are both pan-provincial programs. The Heidi group of physicians supports the pan-provincial Nurses 811 line, and Dr. Ho will speak to that in a moment. On the provider side of things, we created these 24/7 pathways, Mabel, Charlie, Rudy, and Rosie. These are virtual pathways that support maternity care, pediatrics, rural generalist care, and critical care. These were all stood up, the beginning of them was stood up last April 1st in a response to COVID. These 4 pathways are available 24/7. It takes usually about 10 to 15 seconds before a provider answers the Zoom call and appears at the bedside. And really, we've integrated now a relationship with the patient transport network to try to seamlessly bring on all the stakeholders that need to be considered in an urgent call to help move a patient from A to B, but also provide support at the bedside. As a complement to these 24/7 pathways, and I should add that all the clinicians on those Mabel, Charlie, Rudy, and Rosie are all clinicians who are not doing other things. So Dr. Mazurek very astutely pointed out that you know it's a law of diminishing returns. When you're busy in an emergency in a hospital setting trying to do many things, you can't be everything to everyone. And so understanding that inherent nature of being distracted, we double down on not being distracted. And so these docs are all in on calls. They're available within seconds to any rural, remote Indigenous community in BC. So this is, again, a pan-provincial program. And then the other non-urgent supports, the Monday to Friday group, subspecialties are listed below, and I can talk about those later. But I'm going to turn it over to Dr. Ho to take it from here.
Great. Thank you very much, John. Really appreciate the invitation. I'm Kenda Ho. I'm calling in from Vancouver, the traditional territories of the Musqueam, Squamish, and Tsleil-Waututh First Nations. I'm just going to turn a moment to the fact that we will be continuing to talk about physicians supporting health professionals, rural physicians, rural nurses, working together as a team, as a friend. But Heidi is about being a friend to a rural patient, to a rural family, to a rural group of individuals. And I really appreciate Dr. Mezerek's presentation, and really turn the attention to that patients in a moment of need. All provinces, well, most provinces across Canada have the 811 service that's been going for more than a decade, where there's nursing service support patients. When COVID hit in March, the volume of those calls went up. In BC, certainly went up 7 times. And also the complexity of the call becomes much more time consuming. A new disease, patients much more anxious, want facts, and also want to address the anxiety. And so at that time, we were invited as a group of physicians to partner with the 811 nurses together to provide a better service. How can physicians use virtual help to be a friend to any patient that calls into 811? So that 1, we can address their health information. 2, we can reduce anxiety. 3, we can help them navigate our health system. Do they need to go to emergency, or can they stay home? And 4, how do we make sure that they get reconnected to their own family doctors in their local communities for continuity of care. This service was launched on April 6, over 3 weeks. We were able to tee it up. And by March 25th was what you saw on the slide. But by April 6th, that was our first year birthday of Heidi. And when we celebrate that, we actually saw 31,500 patients. 75% of these calls, we were adequate in using phone, but 25% of the time, video was indispensable. A parent, for example, on a Friday night with a toddler who for the first time had fever and vomited 2 or 3 times. His or her struggle may well be, do I need to go to emergency department? And if I take 45 minutes to drive emergency, would that be necessary? And so we were able to go on video, talk to them, and actually see the child to determine how sick they are in addition to description. For example, another young person who now getting fever, COVID symptoms, short of breath, but trying to show a brave face. Yet you can hear the anxiety in his or her voice. Do I need to go to hospital? Should I avoid it? Having video to not only see them breathe, watch for the size that they have, and also understand the anxiety on their face. These are the times I think we as physicians can really partner with 811 together to support that. And very fortunately, we also find that in doing the service, out of 31,000 patients that we have, 3 out of 4 patients, we were able to, after the conversation, downgrade them from needing to go to hospital to actually keep them at home and reduce anxiety. But 17% of those patients, we need to say, you got to go to emergency. We have a rural pregnant lady who have abnormal urinary pattern. And so we said, despite the fact it's 45 minutes, please drive to your local hospital. The next day when we call back, we found out she actually had leaked amniotic fluid. And so these are the moments I think we can not only individually support our patients and friends, but as a health system, we can support them. And so I'm going to try to, I'll pass it over back to Dave now to actually look at the friend of our health professionals, and then we'll go from there. Dave?
Thank you, Kendo. So I'm the technical lead, and they came to me and said, you know what, we need to virtualize this. Let's see what we can do. We've been working on this for about 3 years now, but when COVID happened, it really opened up the funding doors, which is the main barrier at the time. So we'd already been looking at several virtual medicine tools. We landed on Zoom because it is compliant, it is HIPAA compliant. It also runs on every smartphone out there. It is 100% compatible with traditional telehealth carts and the hardware that most health authorities use. You can call a telephone number and have that audio line come in as a part of the case. So it was kind of that one tool fits all kind of a solution. So we jumped on Zoom, and I'm going to actually share my screen here. Kendo, if you don't mind, or John, if you don't mind unsharing for a sec. Okay, so I'm going to share my screen and show you what I'm talking about, and then we're going to do a quick demo, and we're actually going to call an Emerge doc into this session so you can see them and see how quickly it goes. So this is the Zoom window. Most of you are probably familiar with this. If you're not, I'm not sure where you've been for the past year, but everyone's pretty familiar with Zoom by now. So in here across the top, you have the contact button. And on the left, we have our contacts. These are pre-populated in our instance of Zoom. So anybody that has an RCCBC instance of Zoom has these automatically there. We have our RTVS critical care, Rosie, as you can see here. We have Rudy for Emerge. We have Mabel for maternity and newborn care. And we have Charlie for pediatrics. So right now, we're just going to do a demo here with Rudy. Right, as you can see, there's a telephone number after the contact. So that's intentional. The physician, when they come on duty, this is a generic account, so it provides one front door for all providers. So providers out there looking for help aren't trying to figure out who's on duty. This is always the same account. When someone comes on, they sign into the account, they do a warm handoff, the person that was on duty leaves. They enter their cell phone number. So if the technology fails, which it does do from time to time, and the Zoom call doesn't ring through, or the Zoom ring is too low and people don't hear it, the cell phone number there for the provider can be called, and people usually will pick up because they're used to keying on their actual cell phone ring. So that's the backup number to call. So if someone calls, they don't get somebody, they can actually call the cell phone number and ask them, hey, can you please jump on Zoom? I need some help. It's important to note too that all of the ERs in the northern region in BC, through the divisions of family practice and and that's also a hat I wear. We've put iPads on hands-free stands that have Zoom accounts logged in at all times. And so it's kind of like, you know, McBride ER or Valemont ER. So it's the town and the ER. So anybody there can access these supports. You know, if someone comes to the door at 2 a.m. and the physician gets called in and they're 15 minutes out, the nurse on duty can get these supports. They can call them on the iPad and get that support going right away and get that case moving. So now I'm actually going to call in our Rudy line. You can see here there's Dr. Sky Kriba is on duty. So you would just click on the actual contact, and then I'm going to invite to meeting. And because I'm the person that needs help, this should ring on their device. They're going to pop into my waiting room, and that's how we make sure that nobody can jump into the room unauthorized. And so when they come into the waiting room, they're here now. I'm going to admit them. And let's see here. They're just connecting. You can see the Rudy #1. And hi, Dr. Kriba. We have Dr. Kriba here, and she's on duty for Rudy. So if you don't mind just introducing yourself really quickly, Sky.
Hi, my name's Sky Kriba. I am one of the Rudy physicians, so I cover the emergency general inquiries part of the call. I'm based out in Nanaimo. I've been an emerge doc here for 8 years. Yeah, and we're here to help if you ever need us.
Thank you so much, Sky. I'll let you go in case somebody needs to call you for a real case here, but thank you so much for your time today.
My pleasure.
Great. So one more thing to touch on here is you can see how quickly it was. Sky was on with us in 15 seconds. That's how quick you can get help 24 hours a day, 7 days a week. The way we use Zoom as well is, for example, like any traditional ER, if somebody calls Sky and she gets on and realizes the sick kid, she can easily go down, click on the Charlie. She can do invite to meeting, and now Charlie, the pediatrician on duty, comes into the same call. So now we have the ER doc, we have the pediatrician, and so now you're building a virtual team to support the case and support the vulnerable community and the patient. And so this is intentional, and you can add as many layers in as you need. If we need to bring in a team of people, if you have somebody within your network that they're available only on telephone, we can use Zoom to call them via audio and bring them in. So this kind of builds that virtual team real time to support the patient, reduce the anxiety of the rural provider, and hopefully, we get a better outcome. And so I'm going to just stop sharing my screen here. And so that's kind of the gist of how the technology was designed and how it was built. And as I'm at this point, I'm going to turn it over to Dr. Blacklaws to take the next phase.
Thanks, everybody. My name is Bryden Blacklaws, and I'm calling in from the Slam Nation, Powell River, BC. I'm an emerge doc. I've worked in level 1 trauma centers as an emerge doc in TTL, and also the small 1 doctor, 1 nurse places too. And I really appreciate, Dr. Mazurek, your perspectives on and how what you saw going rural after a 25-year career in urban areas. So I really appreciate all you said, and that's really a lot of what we do day to day. And one of the reasons why I'm so excited about this program, because I've just needed help so many times out in rural areas, and it's hard. I mean, who do you ask, right? When you're by yourself, you call people and they're busy. And having this service is just really been changing. For myself, I work in Powell River. It's about 20,000 people. We don't have pediatrics, for example, so I call the pediatric line probably every week. We don't have dermatology. I call the dermatology one all the time. So yeah, I'm really sold on this. I'm really excited about it. It's doing a lot for rural and remote and First Nations communities. And we're really building an emergency, like a virtual emerge. So I'm really excited to be leading the virtual emerge part, or the emerge wing of this program, and also the simulation program. So I've run the simulation program in Prince George and Northern Health, and also built a couple other sim programs, and very proud of this simulation program. So our goal over the next 3 years, we have a nice chunk of funding from the Joint Standing Committee on Rural Issues to build a pan-provincial sim program for rural BC. So we are looking at doing simulations across any rural community that wants it, as well as every residency program in BC, trying to get this technology into small emerges, medium-sized emerges, as well as residency programs and nursing stations. So this asking for help is pretty cool, but it's also pretty culture changing too. So we're not only reaching out to do simulations of a STEMI or a stroke or any difficult case that any of us may deal with at any time, but we're also doing simulation to connect on technology, to connect on communication. And this is not a one-way street. Lori, as you so astutely put, I mean, these clinicians are awesome in these rural and remote communities, and it's as much us learning from them as it is us teaching them. And not only us learning about their community and how medicine is and health is dealt with there, but also in what they have. For example, I recently wrote a STEMI case for a nursing station and published it and felt all proud of myself for doing this STEM case, only to find out that there's no lytics in these nursing stations. So there's just so much bi-directional learning throughout this process. So I'm very excited about the simulation piece. We also are just beginning work on a monthly resident teaching session. Every month we have a rounds that we're inviting residents to, just to connect with the next generation of GPs and the next generation of rural docs. And also those residents are going out and teaching their staff and the other teams in the rural rotations that they're doing. So yeah, I'm very, very excited to be part of this work and really appreciate everyone for having us here today. Thank you. Great, I think I'll hand it off to Helen. Helen, are you next?
Yeah, thanks, Bryden. So I'm privileged to be connecting from the traditional ancestral unceded territories of Musqueam, Squamish, and Tsleil-Waututh people. So just to talk a little bit about the evaluation of these efforts. So social accountability underpins the evaluation, where evaluation is meant to engage, foster mutual learning, build capacity, and advocate, including diverse forms of evidence, stories, and statistics with equal parts understanding and measurement. So together with a multi-stakeholder advisory, the partners co-developed and iterated an evaluation framework and practical evaluation tools and cadences of reporting and knowledge sharing. Next slide, please. So this graphic captures anticipated long-term impacts in areas of evaluation: reduced isolation for patients and providers, improved patient safety, experience and outcomes, increase in culturally safe care, increased health providers satisfaction, confidence, recruitment and retention, reduced costs, and increased access and use of technology at the point of care for timely advice and support. So next slide, I'll just highlight 4 of the peer support pathways and paint a quick picture of growth of calls and virtual encounters over time. So as John noted, these real-time virtual support pathways provide 24/7 support in critical and emergency care. That's Rosie and Rudy, which launched April 20th. Pediatrics, Charlie, obstetrics, Mabel, which launched July and August respectively. So to mid-March, the 4 pathways, peer-to-peer pathways, handled over 2,250 calls and cases. Around 90% were clinical cases of varying complexity, engaging various partners and time over time. One of the cases was an interprofessional collaboration that saw the first birth of a baby in a remote community since 20 years. Next slide, please. I'll just share a bit of a snapshot of reach and communities supported by these pathways. So since launch to mid-March, almost 28,000 hours of support have been offered, primarily clinical support, and as Bryden noted, support in simulation, education, training, other types of collegial support. Pathways expand this team-based care for vulnerable providers and communities. And to the date of this report, have reached 86 unique communities, and that reach continues to grow. And the point I really want to emphasize here is that most calls come from colleagues in rural and remote and First Nations communities, progressively achieving the goal of advancing equity for the most vulnerable providers and communities. Next slide, please. So evaluation findings have yielded these themes over the year that serve as guiding metaphors for this suite of real-time virtual support services. And there's some quotes from participants there, but RTVS is a needed safety net for patients to access timely, appropriate care wherever they are in BC. It's a funnel point for patients to enter and re-enter longitudinal team-based care on their journeys. And beyond high-impact clinical cases, it's a fire station delivering mentorship, capacity building for vulnerable providers in rural, remote, and Indigenous communities. And above all, cultural safety must be the beating heart within the design and delivery of virtual care. So next slide, please. So just building on this strong foundation of partnerships and relationships. This work is grounded in person-centered team-based care. It brings together communities, health professionals, clinicians, administrators, decision makers, academia, and linked sectors, all focused on this common goal of advancing equity and wellness for rural and First Nations in BC. So, thank you.
Thanks, Amy. We'll pass it back over to you.
Wow, thank you so much for sharing all of that. I know the first time I heard about these projects, I was mind blown at all that's been accomplished and developed in the past year. So really interesting projects that you've come up with. And I've definitely been on the receiving end of some of these, receiving great referrals to the emergency room from Heidi physicians. And being a relatively new grad, I see the benefit for this for rural recruitment and retention. The rural physicians are the safety net for the patients, and I see all of your resources are the safety net for the rural practitioners. So thank you so much for the work you're doing there. We're now going to move on to our panel discussion and the Q&A. And I'd like to start by taking this opportunity to welcome our two additional panelists. First off is Howie Isaac. He's a critical care air ambulance paramedic with over 20 years of experience in the field. He also has personal experiences being from a small Indigenous community, so he's witnessed some healthcare changes in those areas as well. Brenda Lambert has over 30 years of experience in emergency medicine nursing, management, and teaching, and she's been working the past 3 and more years in rural Northern Ontario. So thank you both for joining us to round out the perspectives on our panel today. I wanted to start the discussion first by giving some questions to both Howie and Brenda to get your perspectives. So the first one I'd like to talk about is how do these technologies influence patient transfers, either improving care prior to transfers or perhaps limiting the need for transfers. So I'm wondering, Howie, after hearing about these two presentations, if you have any feedback from your job.
Hi, Amy, thank you. First of all, I come to you guys from the Moose Creek First Nation in the James Bay in Ontario. So to your question, Amy, how do these technologies help us in doing our jobs in the remote north? Telephone consult has been the bulk of our business and communicating with our docs and receiving directives. It's efficient. We use landlines, sat phones. Sat phones aren't that reliable, but in the last, I'd say 6 years, virtual critical care is come into the picture, and I've used it several times now. It does impact patient safety in a good way. And it does lend support to the practitioners on the ground. It just gives you that extra boost of confidence and an extra set of eyes and an extra mind to help you through your difficult patients.
Great, thank you. I'd like to ask Brenda the next question. In Lori's presentation, there was a discussion about kind of expanded scope for nurses, maybe PAs, and nurse practitioners. I'd like to hear your experiences, Brenda, working in the remote north, and I understand you have some expanded scope and maybe what some of the supports you would like to see for nurses in those settings.
Yeah. Well, having worked 20 years Sunnybrook Emerge, I now get to work at my full scope of practice as far as I'm concerned. I don't have to, I get to do my own suturing. I get to run my own codes, which is perfect for me because I've got lots of experience. And my first 6 weeks, I was scared to death. So I look at all the new grads that are coming up and I think, wow. And they keep saying, well, how long till I'm not going to be scared? I said, you should always be scared. So being able to have a physician at the end of a phone quickly, and I mean, we've got, systems where we can call level 1s, level 2s, but I love what they've got in BC, that I could pick up a phone and initiate the Zoom and have someone who's waiting to actually help me with that. I think the other component, though, is as a physician, you may know, okay, you need to start a drip, but the nurse maybe has never run a drip. And you as a physician aren't probably going to be able to walk him or her through how to do that. So you almost need both of those experience levels. So for me, this is my perfect retirement job. I get to teach, I get to mentor, and I get to do amazing patient care in a setting where I'm not run off my feet like I would be in a Southern emergency department. I get time to actually, so I think from a, recruiting piece, Lori talked about physicians and it expanding and lengthening their careers. I think the same can happen for nurses who, have that experience and maybe can spend 20% of their time up and can maybe support over the phone. But what BC has done would be huge for us.
Those are really great thoughts. I wonder, from the BC group, have you incorporated nursing or paramedics involved in your mentoring as well?
Amy, it's John here. I can jump in. I just want to thanks Brenda for highlighting that. As Helen showed in the evaluation, actually the remote nursing stations, the remote Indigenous communities are actually the heaviest users of our 24/7 RTVS lines. And it has been nothing short but transformative for those nurses. And we've actually hosted visitations by nurses from communities like Atlin, Quadacha, Takla, to come to RTVS meetings to share their story of how things were prior to the RTVS work and how they are now. And so at best, it was a situation where a nurse with a sick patient had to call a regional hospital somewhere, sometimes in another territory or province. So for Atlin, for example, you'd call Whitehorse or over the Alberta border. And then somebody's busy, as Dr. Mazurek pointed out too. And a lot of times the calls don't come back for hours. And if you fast forward to today, where that same nurse now just hits a button and somebody appears, and that somebody is not only responding in a timely way, they've actually been selected for their human qualities. So for their thoughtfulness, their compassion, they consider what they don't know about who is calling and where they're calling from. And for those reasons, all those collective reasons, you have somebody who is better aligned to help support those people on the ground. So I think it's, we do have, nurses are a big part of obviously who we work with in terms of reaching out, and we integrating nursing into the RTVS network, if you will. Our faculty is on our to-do list for 2021, and we do have nursing participation.
That's great. We had a question come in from Pravina, and there's a few different facets to it. So we'll direct different pieces to different panelists. To start, she's wondering about point of care investigations like ultrasound, cardiac monitoring, VBGs, and how these could be integrated with telemedicine. So maybe virtually supervised POCUS and things like that. I know there's work being done in BC, so I don't know if who wants to take that on first. Maybe, I know.
Bryden can take that on.
All right, great. Well, I can speak to the POCUS one. So bedside ultrasound is something that all of us clinicians use basically every day in the emergency department. And COVID has really put a damper on a lot of the online or a lot of the in-person teaching for ultrasound, as we all know. All those fun boot camps that we were all part of before are all essentially done. So the rural CPD, the Continuing Professional Development, has funded and produced the first, in BC anyway, virtual house course. House is our name for our basically EDI 1. So we have actually been successful in doing a virtual EDI 1 course, which is awesome. We have a project ongoing through RTVS for a whole year of POCUS training. So we're doing training for RTVS doctors to help interpret scans for rural communities. We've also had some funding to help put things like butterflies into rural communities, like those handheld ultrasounds. So we're getting to the point where we can actually, where we have a project and a few leads for ultrasound through RTVS that are looking at setting up rural communities with POCUS that we can just look right through with the butterfly through RTVS. So it's really fun. I mean, it's really pushing the envelope of technology. So yeah, that's really fun. In terms of point of care and bedside tests, I mean, one of the biggest challenges to, our main user is nursing stations, rural nursing stations who have usually a glucose, a urine dip, and an ECG. That might be it. I mean, John, you'd know a lot more with your 20 years of working in remote areas, but it's really not much. So I haven't been in the situation where I've been walking someone through a VBG personally, but you know, we can walk anyone through anything best we can. But these nurses are so great and they're awesome. And one thing I will throw out there, and Brenda, I'd appreciate your opinion on this, is I don't know what the stats are, but the majority of the nurses we've been working with over the past, let's say 6 months, have been agency nurses. A lot of them working for the first time in some of these communities, which has been a fun thing because a lot of them are young, a lot of them are really new, and a lot of them bring a lot of neat perspectives and new experiences, and a lot of them aren't the 20-year vets that I remember talking to a few years ago. So yeah, I hope that answered the question. I mean, there's so much room for improvement on the bedside investigations piece. Yeah, if anyone wants to comment further on that, but it's a fun ride. It's a fun ride trying to figure all this out as we go.
Amy, it's John here. If I could just add to Bryden's comment, the one thing we didn't touch on, Bryden did allude to UBC continuing professional development. So they're a strong partner in the RTVS network, and such a degree that CPD now endorses and validates the call. So we aspire to the belief that clinical support and education need to merge at the point of care. And so to that end, when a rural physician like myself in Takla calls Bryden or a critical care doc on Rosie at 3 a.m, that call is now captured under UBC CPD, and I'm eligible for CME credits through UBC. And so we validate the call as being an educational experience in addition to be a clinical support one.
Oh, that's great. Further to the technology, I know there's some interesting future projects that the BC group is working on. I wonder if John or Kendall want to speak to the drones and robots.
Yeah, I can speak to the drones. So we're just embarking as they have it. You have in Northern Alberta. I think Howie's in a area where they've done some work with drones in Northern Ontario, but essentially starting the journey with drone technology for rural and remote and Indigenous communities, not unlike we did, over a decade ago with virtual health, and where people thought it was quite awkward and inappropriate almost. You get the same kind of looks with drones, but I think COVID's helped kind of liberate people from some of their traditional thinking around why this technology might make sense. And the healthcare chain, if you will, supply chain is one reason to move products, testing equipment, PPE, that kind of thing, to remote sites. I showed you the slide of Takla. It takes about 6 hours to get there to get a COVID swab from there to Prince George. So that's a problem. And so, how can, fast forward to drone technology, what role could drones play in moving laboratory testing equipment from A to B? How about pharmaceuticals? And then Indigenous communities that we partner with also have a lot of, they exist in the middle of a forest. We have forest fire season every year. They have floods. We have natural disasters that happen. How can drones help support that? So we're cutting our teeth in BC on this, on a partnership program with the Stalatin First Nation and the University of BC.
So 2 quick things about the robots and the data. We have very fortunately partnered with a company with the supercluster funding to look at how do we use robots as an extension of the virtual care provider to examine patients. And so I think that's going to be a very exciting area to look at. How do we supplement the verbal cue to unusual or standardized physical examination that historically cannot be done. But in addition to that, we're very interested in using sensors and different ways to capture the signals of the patients so that those signals can not only be helpful for us in the face-to-face encounters, but actually capture the data and using data science and using machine learning and artificial intelligence to start to look at the population health and also start to predict outcome. So very exciting work. And again, not ready for prime time today, but hopefully in 2 or 3 or 4 years, more and more of that would show up in virtual care.
Very exciting. We've got a question from the audience regarding how is the clinical course documented when the clinician is supporting from a distance? So perhaps like the Rudy physician, how are you documenting your care? I don't know if Dave wants to take this maybe, or perhaps one of the physicians.
I'm going to actually let John take this, the clinical piece.
Sure. So really great question. And so in parallel to the emergence of the RTVS clinical pathways that you've heard about, in addition to the Zoom communication platform that Dave talked to, we actually partnered with the Ministry of Health to set up a pan-provincial EMR for these pathways. And so that was a huge amount of work that's still undergoing. We're actually just in kind of the EMR 2.0 version of the work that Brad and I have been involved with, now understanding what now needs to be considered as we're essentially building a virtual emergency room for BC. And so when a Rudy doc sees a patient in any rural community, they will document that on this provincial EMR. And then that encounter note will then get pushed back to the rural community, but it also can go through a pathway known as Care Connect in BC. So if the patient's being transported to Kelowna or Vancouver or Prince George, the receiving site can access the Rudy note from Care Connect. And so it's the first time that we've actually in this province for this kind of work been able to establish a pan-provincial electronic medical record, which we're just getting better at, but all the providers, Mabel, Charlie, Rudy, and Rosie, document on the same EMR. And in fact, when a Rudy doc comes on, so we've had numerous cases where a Rudy doc will get called at 2 a.m. They'll help a community till 7 o'clock in the morning, and then they have to hand over to the next Rudy doc. And so the longitudinal record is all there for people to see, and that can be shared as well.
That's really great. I think most provinces are hoping for a province-wide EMR that would really ease a lot of communication barriers. So happy to see that's underway. We have time just for maybe one more question. We're going a little bit over here, but I just wanted to touch on a piece that was mentioned in Lori's talk and I've heard brought up several times, is the issue around the urban physicians, often urban-based specialists that are providing support to the rural practitioners. How do we ensure that the feedback they're giving is helpful and understanding the context of the rural providers as well as the rural patients? So one solution proposed by Lori was the idea of the locum plus, where those urban physicians spend some of their time in the rural context. I'd like to hear from others if there's further suggestions in that area.
So I can jump in, Amy and Brian can speak to this as well, because part of the, it's a really good point that Dr. Mazurek highlighted, and it's certainly in my clinical practice, with Caris County Family Services, we predicate virtual health on that relationship-based care that is partly complemented by in-community presence. So that makes really good sense. Having said that, for the RTVS work, that's more broad, and we have a roster of docs from across the province that are participating. That's not possible in our model, but what is possible is to screen for the right people to do the work, and to that end, aspiring to those things that Helen pointed out in the slides around, cultural safety, about compassion, thoughtfulness, and about rural education. And so a large part of our fire department work is, again, COVID's put a little bit of a press on this, but we do a lot of community engagement work to learn about what our communities needs. And so once COVID lifts, Brian and team will be taking docs out. We want to take the critical care docs, the Charlie docs, out to TACWA and these communities to meet the people and to see what it feels like to stand at the bedside in this super remote place. And, you know, what would it be like to have a patient who's really sick in front of you and you don't have all those fancy things that you have in your center? So that community engagement work is really important. Brian, anything to add to that?
I feel like it's speaking to the converted here. I think anyone that's worked in a small rural community understands just how rewarding that work is and also how challenging that work is. And you know, I've done a few years of trauma team leader work and seen lots of trauma, and I've never been so uncomfortable in my whole shortish career as I have been by myself with 2 trauma patients. It was just, the whole thing changes when you feel that feeling of no CAT scanner, no anesthesia, no residents, no critical care nurses. The nurses you're with have 1 year experience and you only have 6. And it's so scary. It's like that feeling of I'm really uncomfortable, and having that feeling as a rural doc really puts all this work into context. And I think that's why a lot of us are here. We want to improve health and support for our rural colleagues and rural patients. And I think that's why we're all here. So I'm just really excited to be part of the team.
Amy, if I can add maybe just 15 seconds. I think in the area of real-time virtual support, there are 3 elements that really strengthen delivery of service. It's e-presence. When the need is there, that someone is there. E-knowledge. Someone can trust on the knowledge so that the service can be delivered. And e-trust. The ability that that person can be trusted. And it's a two-way street. And we've been, I think that today's presentation speaks very, very loudly about this, that in fact, all of us need to have a learning heart and really open up and to learn from each other in delivering this care. If we can achieve those 3 elements with an open learning heart, I think it will do us very, very well.
Those are some really great points. We are going to have to end tonight's discussion. And I think that's a great ending thought to bring about the partnership that we all have, and also to recognize the clinical courage that all of our rural colleagues are facing as they work in these challenging environments. So finding ways to support them moving forward. Then it's been a really exciting discussion, and I know there's lots of excitement from our group on how we can form further partnerships and move forward with some of these ideas. So thank you all for your time. I want to thank all of the viewers for your participation and for your questions. I want to thank the panelists, Lori Mazurek, John Polovich, Bryden Backlaws, Kendall Ho, Helen Novak-Lauscher, Dave Harris, Howie Isaac, and Brenda Lambert. Thank you all for taking the time tonight, as well as the many CAEP staff that have made this event possible, specifically Gail Chapman, Marika Moskalik, and Jeff Allen of Jeff Allen Productions for your live support to make tonight possible. And also thank you, Paul Pajot, Dr. Paul Pajot, for the invitation for us to present today. A reminder to please complete the evaluations so we can continue to improve these sessions, and certificates will be sent out to those who registered tomorrow. Thank you all. Have a safe and good night.